Just give this another minute. I see people are still coming into the waiting room. All right, well, it is 5 o'clock, and Paul, I know some people are still coming in, so if you would let them in, but we will go ahead and get started.
Okay.
Welcome, everyone. My name is Erica Ferriston. I am the chair of Healthcare for Us. I co-chair along with Gina Viola, if she wants to give a little wave there. And Healthcare for Us is an all volunteer, nonprofit, nonpartisan organization committed to achieving single payer in California and fighting the larger fight for healthcare justice in the nation. Our website, if you want to check us out and learn more, is really simple. It's HC4us.org, and that stands for healthcare4us.org. So I'm going to give a brief overview of CalCare, although I feel like everybody on here probably knows what CalCare is, but we are recording this. So perhaps those out there need a little reminder. So CalCare is the name of the California single-payer healthcare bill proposed by the California Nurses Association. Another common term for single payer is Medicare for all. This is an improved, expanded Medicare for all bill. And the actual long name of CalCare is the California Guaranteed Healthcare for All Act, but the nickname is CalCare. And this would guarantee comprehensive, high-quality healthcare to all California residents as a human right. The establishment of the CalCare program is a Medicare for all type program, but like I said, it's actually expanded and improved Medicare for all, and it's based on 7 principles. The first is universal coverage, which means everybody in, nobody out. Everybody, regardless of race, sex, gender, country of origin, income level, employment status, immigration status, every single human being in California would be covered. It is a single public program. What does that mean? That means public funds are pulled into a government guaranteed trust. That's the single payer part. And then that trust would pay your healthcare providers directly, sort of like traditional Medicare does. There are no insurance middlemen when it comes to single payer healthcare. So they don't get to profiteer off of our suffering, illness, or death. And abolishing the health insurance companies saves money and saves lives. And some of you may ask, well, is this government run healthcare? And I would say, why no? It is not government run healthcare. It is government paid for healthcare. It is publicly funded and privately delivered. The third principle is fully comprehensive benefits. This includes all medical, mental health care that you would possibly need, including dental, hearing, vision, long-term care, prescription drugs, you name it, it's covered. Freedom to choose your care provider is the next principle. No more in-network or out-of-network. You have the freedom to choose any doctor or healthcare facility you like. Free at the point of service, no more co-pays, premiums, or deductibles. You arrive at your doctor's office, show them your CalCare card, and get the healthcare you need. That's simple. Just transition. Of course, the nurses union wrote this, so they are looking out for the workers, and this is funding and programs to protect and support any displaced workers in the insurance industry. And I will also just add on to that, this really is a job creator and a revenue generator bill. And finally, patient care based on patient need. No more financial incentives to avoid providing necessary care. including value-based payment models for providers. So if you need the MRI, you get the MRI. If you're only be given an MRI so somebody can profit from it, then you don't need it, you don't get it. So all your healthcare needs are met with CalCare. And again, we have more information about CalCare. We have the text of the bill. Right now, the bill, so CalCare AB 1400 was the number associated with CalCare last year. Right now, the number is 1690. It's a spot bill to allow for legislators and grassroots organizations to work with the nurses on developing some content or language of the bill, but the fundamentals of the bill are set. The principles that I just laid out will not be changed. And so if you want to read more about the bill, go to our website, hc4us.org. And with that, I'm going to turn it over to Maureen.
Welcome, everybody. Thank you so much for joining us. It's my pleasure to introduce Kip Sullivan, who is a prolific and incisive researcher, analyst, and author of healthcare policies and reform efforts for decades. Mr. Sullivan has written several hundred health policy articles and healthcare reform articles for publications like the American Journal of Public Health, the Journal of Health Politics, Policy and Law, the LA Times, The Nation, New England Journal of Medicine, the New York Times, and many, many more. Probably a few hundred articles over the decades. So Kip's focus is performance measures, quality assessments, hospital and insurance revenue data, and healthcare costs. Kip's data-driven analyses have always been in the service of single payer, specifically targeting single payer's primary competitor, managed care. His critiques and comparisons of both states and national healthcare legislation are essential reading for single payer advocates. And a little personal history is always fun. After earning his law degree from Harvard, Kip Sullivan initially worked for the Juvenile Rights Division of New York Legal Aid Society. He became active with a variety of citizens' health policy action organizations in California, because he was here then, and in Minnesota since 1976. And he fell in love with organizing and research on health policy. So Kip served as a consumer representative on the 1989 Minnesota Governor's Health Plan Regulatory Reform Commission, and as a health systems analyst for the Minnesota Universal Healthcare Coalition. He was a founding board member of Healthcare for All Minnesota and is now a member of Healthcare for All Minnesota's Legislative Relations Committee. So welcome, Kip. We're so happy that you are able to spend this time with us.
Thank you very much for having me. I just want to let you know that the Healthcare for All Minnesota Board was alerted to SB 770 by somebody in California with DSA. We have some DSA chapters here in Minnesota, and this person did not like SB 770, and the reaction from the Healthcare for All Minnesota activists was to pass it on to all of us. And we haven't taken a position on it, but safe to say that people that chimed in do not want the concept.
Could everybody mute?
Suffice it to say, the people that have commented do not want the concept of unified financing entering the debate here in Minnesota. I want to begin by explaining to you why I'm well informed about California health policy and the California single payer movement. And to do that, I need to tell you some of the history of the Minnesota single payer movement. And I think you'll see it's very relevant to the debate, I put it in quotes, about SB 770. I was one of 4 people who drafted Minnesota's first single payer bill early in 1990. It contained the 4 fundamental elements of a single payer system. Those 4 elements are one payer, as Erica was just telling you, replaces hundreds, or at the national level, thousands of insurance companies. 2, the one payer negotiates budgets with hospitals and in Minnesota nursing homes. We have 140 hospitals here, so the single payer would negotiate 140 budgets. 3, it negotiates a uniform fee schedule with doctors. And 4, the one payer negotiates limits on drug prices. We endorsed single payer in December 1989, we being the coalition I had helped form at the time, for one very explicit reason. Namely, it was the only proposal that could cut costs. 2 years earlier, we had cut our teeth on fighting for legislation by proposing something called health span. It was a bill that would have expanded coverage to people too well off to get Medicaid, but not well off enough to afford insurance in the private market. And it was defeated because we simply had no answer to the question, how are you going to control healthcare costs? You may recall in the late 80s, healthcare inflation was torrid. The nation had never seen healthcare inflation like we were seeing in the late 80s. So we learned our lesson. We spent 1989 in multiple cities around Minnesota talking to our coalition allies about what's the best solution to cost containment. Our choices essentially were high deductible policies promoted largely by conservatives. We rejected that out of hand. And as you can imagine, being in the Twin Cities in 1989, the home of the HMO revolution, along with California, we heard a lot about managed care, but we couldn't get any evidence supporting the claims for it. We did feel that since single payer made sense, there was some evidence for it. And that's what we endorsed in December 1989. Single payer systems cut costs primarily by cutting administrative costs. And because they cut administrative costs so substantially, you really don't have to rely on squashing provider reimbursement. You can justifiably reduce it somewhat to recoup the saved administrative costs. The reduced administrative costs are roughly half and half, reduced in the insurance sector and reduced in the provider sector. By 2003, our single payer bill had several hearings, but it never cleared a committee. We were intrigued, therefore, to hear that a single payer bill, SB 921, passed the California Senate in 2003. We were perplexed, however, when we learned that SB 921 had a loophole in it for HMOs and no hospital budgets. A report by the Lewin Group, released by SB 921's author, Sheila Kuehl, in January 2005, to confirm our conclusion. According to Lewin, SB 921 authorized funneling tax dollars through HMOs. They used that term. Early in 2005, a half dozen members of the coalition I was working with met with the chair of the Senate Health Committee to discuss her support for hearings on our single payer bill. Thinking she was being helpful, she suggested to us that we consider substituting SB 921 for our bill. Again, she was thinking, well, something happened, something magic happened in California. What if we do that here in Minnesota? We might get a bill through the Senate or the House. We politely rejected her suggestion out of hand. We had no illusions about HMOs, and we understood how single payer systems save money. 2 years later, we had to deal with Senator Kuehl's bill again. This time, the number was SB 840. Here's how it happened. In 2006, the Minnesota Universal Healthcare Coalition raised enough money to hire a half-time lobbyist. I'll call her Ellen. Ellen knew a lot about lobbying, but not a lot about single payer and how it cuts costs. Early in 2007, without asking the board for permission, she replaced our single payer bill with SB 840. She told dozens of legislators that the new bill was authorized by the Minnesota Universal Healthcare Coalition board. She got dozens to co-author, and then she published a press release announcing the new bill. Some of us just about popped our ears out when we saw this. By then, a House Research Office had concluded, as the Lewin Group had 2 years earlier, that Senator Kuehl's bills, and now our bill, is a multiple payer bill. You can see how a novice like Ellen could be fooled. SB 840 did not use the phrase HMO. It used a euphemism adopted by Kaiser Permanente at the height of the HMO backlash in the late 1990s, integrated delivery system, specifically capitated integrated delivery system, which means an entity bearing insurance risk because it's paid on a per head basis. Moreover, the media and SB 840 advocates were describing the bill as a single payer bill. So I have sympathy for Ellen's mistake, but we fired her 2 months later. She should not have, if she had checked with the board, this wouldn't have happened. But some damage had already been done. Legislators and the coalition board members were embarrassed. Feelings were hurt. It took us really the rest of 2007 to restore unity within our movement and good relationships with our authors. So you can see why by 2007, I and other Minnesota single payer advocates were highly voted to find out why California Nurses Association, California PNHP, and other California groups supported the HMO loophole, and why, whatever their reasons, they applied the single payer label to a multiple HMO bill. We got no answer from CNA, and I know some of you know what I'm talking about. We got an answer from Senator Kuehl's office, but it was to the question, is the loophole, the integrated delivery system loophole, is it just for Kaiser, or is it for any and all HMOs that may show up and ask to be certified? And the answer was any and all HMOs. And the staffer said Sutter was an example of a chain they expected would leap at the opportunity of being an HMO. We did succeed in generating a conversation with California PNHP's board. And Don, I think you were part of some of these conversations that followed. Chime in during the Q&A if you feel I've left something out here. It began when California PNHP's chair at the time, Matt Hendrickson, invited me to fly out to LA to discuss how to get rid of the Kaiser loophole, as I think he referred to it. We decided instead to hold phone conference calls. We held a half dozen conference calls. I think there's 7 or 8 of us on the call. A couple of staff people from the Chicago PNHP office and California PNHP board members. Some in late 2009 and others running into 2010. To make a long story short, I came away with 2 conclusions. First, that Kaiser really is the main problem, but no one I could say could tell me why it's a problem. What is it that Kaiser defenders fear if the Kaiser loophole is removed from a California bill? Occasionally I might jest and say, do you think the governor is going to send the National Guard out with bulldozers to destroy Kaiser clinics and hospitals? I didn't mean to be too sarcastic, but I just couldn't get the answer. What is it you fear is going to happen if we get rid of the insurance component of Kaiser and people continue to see their Kaiser doctor in clinic? The other conclusion I took away was that California PNHP did not feel that their input to CNA was welcome, that they would not have much influence. CNA by then had a reputation for not seeking input on their single payer bills. PNHP's pessimism turned out to be well-founded. Successor bills, SB 810 and 562, contain the same loophole. So I hope you can imagine my surprise and joy when I learned in February 2021 that CNA had introduced another single payer bill, AB 1400, that did not contain the HMO loophole and did authorize hospital budgets. But my expectations were dampened when I learned that a new California group called Healthy California Now wasn't supporting AB 1400, at least initially, and was instead promoting a novel idea that a state should pursue discussions with CMS about waivers for enacting a single payer bill or even drafting one. Senator Wiener introduced a bill based on this novel premise on March 21, 23, SB 770. Now, it's very difficult to understand SB 770 and therefore to predict its consequences if it is enacted. And I'm going to list several reasons for you, and then I'm going to pull up some slides and go back over this same territory in a little more detail. Reason number 1, the language is vague. It says that the Secretary of California HHS shall pursue waiver discussions. And it says the work group that is established is supposed to, quote, advise the governor on topics related to federal negotiations. Can you imagine trying to develop an agenda based upon instructions that vague? The vague language does not support the claims such as that SB 770 creates, quote, tangible steps on a concrete timeline. There are no steps. There's no timeline in SB 770. And there's one tangible step, and that is a report due on June 1. Reason 2, the purpose is unclear. Some parts of the bill and some statements by proponents suggest the bill's purpose is to write a waiver application, while others suggest that the purpose is to write a new bill based on what quote unquote stakeholders are going to tell the work group and what CMS might tell Secretary Ghali. Third reason why it's so difficult to make sense of SB 770 and predict its consequences. The premise is questionable. The premise is that CMS can tell Secretary Ghali something useful about applying for a waiver for a bill that the state legislature has not enacted, or even drafted. I don't think it's ever even been proposed before, and it certainly hasn't been done before. Fourth reason, the waiver is for something called unified financing, which is neither fish nor fowl. It is both multiple and single payer, according to the people who coined the phrase, which were some legislators in California and then the Healthy California for All Commission. And to add to the mystery, advocates of SB 770 say it means only single payer, when in fact the commission clearly stated it means both a single payer and a multiple payer system. Reason 5, the commission and HCN claim that Medicare and Medicaid waivers are essential. The implication is there's no point in passing single payer at the state level unless you get the feds to cooperate and let you roll in Medicare and Medicaid money. You will find that statement made in the commission report. You find it on the HCN website, but you don't see a rationale for that. There are a lot of people in the state single payer based movement who disagree with that, and I'm one of them. We'll talk about it in the slides. Sixth reason, statements by 770 proponents that the fundamental issue raised by 770 is the role that Kaiser will play in a reform system. Now, that's an issue that is raised mostly with me privately. I've got friends on both sides of this split in California, and I hear from advocates of 770 vague statements to the effect that, Kip, you really just need to understand what it's like to operate in a state with Kaiser. Fine, tell me what it is what it is that concerns you. I just don't get answers, but I list it as a sixth reason because it adds to my confusion. I think there's a motive here that has something to do with Kaiser, even though it isn't mentioned in 770. So my goal tonight is to list the most important questions about SB 770 need to be answered, preferably before 770 passes, but after the June 1 deadline has come and gone if necessary. If SB 770 actually achieves something useful, then single payer advocates at the state level around the country are going to want to know how it happened. I doubt much useful is going to happen. I doubt whatever happens will be useful enough to have delayed progress on CalCare for one biennium. But I'm not here to say nothing at all could possibly good come of it. I'm just telling you, I doubt it. If, on the other hand, SB 770 fails, we're going to want to know how that happened as well. Most importantly, tonight, if we're ever going to heal the rift between SB 770 proponents and opponents, we're all going to have to address these questions and ideally agree on the answers to them. And I'd love to see a genuine debate where we get these questions out. So that's my goal. I do think the longer these questions go unaddressed, the harder it's going to be to repair the split between the pro and anti SB 770 advocates. So I'm going to take about another 25 to 30 minutes to go over these slides. I put them together today and didn't have enough time to make sure they're in the order I want. Let me just get going here. I think what I'll do is I'll stop at about the 30-minute mark, 25-minute mark, wherever I am, and we'll begin to take questions. By the way, if I say something you flat out don't understand, if it's jargon, please stop me. I'm happy to explain. Otherwise, let's save questions to the end. But do please keep track of your questions. All right. I'm going to skip over slides that deal with the pre-AB 1400 bills in California, just to make sure I cover the SB 770 issues well. I'll come back to these if I get through the 770 slides. I do want to call you, I'll stop here just to call your attention to one excerpt from a paper published by Healthy California Now and written by Ian Lewis. I believe he's the policy expert for NUHW. And I've been told that he wrote SB 770 along with Lighting. And I call your attention to this excerpt from the report because it's accurate. It indicates he understands the literature on single payer. He's accurately stating that the largest source of savings achieved by single payer is to get rid of administrative waste generated by the insurance company. And he says the total waste amounts to about 15% of total healthcare spending. So at the national level, that's 15% of about what, 4.4 trillion. And accurately enough, he says half of that is saved in the overhead of providers and the other half in the insurance industry. Now tuck this excerpt away in your head, because I'm going to quote something that Ian said on the radio or on a podcast that suggests he has forgotten this. All right, issues raised by 770. I've got two slides here summarizing my questions. What is the bill's purpose? Is it to write a waiver, or is it to write a bill based on input from CMS, which may or may not be favorable to single payer, and the stakeholders, that's taken from 770, who attend the work group's hearings? We don't know who they are, and the mission of the work group, as we'll see in a minute, is broadly defined with the most abstract language possible. What useful advice can CMS give Secretary Galley before a bill is enacted, or at least drafted? What questions can CMS answer that are not already answered by federal law, federal regulations, or the commission's report? I can imagine CMS could answer lots of questions if Secretary Galley shows up with a bill. Even if it's not enacted, he's got a bill. I can imagine this conversation being productive. But with no bill, I honestly am baffled by the belief that Secretary Galley can phone up CMS and say, let's negotiate a waiver. And when they ask him about what, he says unified financing. Sub questions under this second issue. Is it true that CMS can tell Galley how much Medicare and Medicaid money California is going to get? Again, when you've got no bill to show. A, I don't know how you even make a wild guess if you don't have a bill to discuss. And B, I don't know how you bind CMS, even under the same administration, a couple of years from now when California gets around to passing a bill, much less if they take so much time that we're not talking about a new administration. But you can tell from the way SB 770 proponents talk, that's what they think is going to happen. Somehow, and the commission, by the way, talk the same way. Somehow CMS can tell Galley, this is how much Medicare and Medicaid money you can count on, even though you don't have a bill to talk about. Here's an odd one. I've asked several SB 770 proponents this question. SB 770 says that California HHS has already had, quote, preliminary discussions with CMS on the terms that would provide of a waiver for unified financing and full federal financing for unified financing. Wouldn't it be interesting? Wouldn't it be extremely helpful to know what happened at these initial conversations? I think so. I mean, maybe something actually good happened. I doubt it. But boy, if I were SB 770, an advocate for 770, I'd trot those. If something good happened, I'd have that out on my website tomorrow. I can't get answers. Something tells me this conversation never happened. More questions. that I hope all of us will discuss sometime in the next 10 to 11 months. Why does SB 770 refer to unified financing 10 times and single payer only once? Why do HCN representatives claim that unified financing means only single payer? When we know the commission made it crystal clear, unified financing means both a multiple intermediary system, as they call it, and single payer. How long will HCN continue to use unified financing instead of single payer exclusively? Section 1332, a Section 1332 waiver is necessary. There's no two ways about it. But it is not true that a Medicare and Medicaid waiver is absolutely necessary. There are workarounds. There are benefits to a single payer system that applies only to the non-Medicare, Medicaid population. How are Secretary Galley and the work group supposed to get their work done by June 1, 2024? And I'll show you a slide taken from a report to the California Assembly Appropriations Committee, where it indicates that HHS, presumably Galley himself, has said there's no way we can get our work done by June 1. So what's the answer to that question? Is HCN going to then demand that another biennium go by while Galley tries to talk to CMS? And then lastly, why do single payer proponents bring up Kaiser and capitation in the context of SB 770? And again, I can't point you to a public document. I'm referring to communications I've had with a half dozen SB 770 proponents. Is it HCN's goal to insert the integrated delivery system loophole or the capitated intermediary loophole in a bill, either CalCare or another bill? If so, why not announce it now? Why keep it a mystery? And if that's the goal, how does HCN propose to address problems that we know, for just looking at Medicare Advantage, occur when you start paying risk-bearing entities capitation premium payments, upcoding, bad risk adjustment, denial of services, and surprise bills? Now I'm going to go give you some documentation for these questions I just asked. This is language taken from SB 770. I have put in blue and red font the more critical phrases. The red font is I'm using for really vague language. So you see, structure number 1 is the Secretary of HHS is going to pursue waiver discussions. What is it going to be about? Well, we can't tell you what it's about, but we're going to list 20 features and objectives that we'd like the bill that we haven't written to have. The instructions to the work group are a little disturbing because they are not only vague, they suggest that the purpose of the work group is to come up with a bill that doesn't look like CalCare. But I stress it, only suggest. I don't know for a fact. Work group shall undertake a program of stakeholder engagement, and it lists various things that they're supposed to address. The specifics of a transition to a unified healthcare financing system, adapting existing consumer protections to the new system. If anybody has any idea what this sentence means, please email me. I know you don't. Applying reforms. What reforms? To move towards systems. What systems? And to enhance the comfort and security of Californians. Note this last instruction. Secretary is supposed to report to the legislature by June 1, recommending elements of the formal waiver application, along with all legislative action necessary. Why say, what does action mean? I think that you're talking about another bill. If they're not talking about a bill other than CalCare, it would be helpful to hear that that's the intention. Here's a statement from the NUHW website indicating that these instructions to the stakeholders do suggest that the work group I'm sorry, the instructions to the work group indicates that they really are supposed to go out and beat the bushes for stakeholders to come in and testify on building a better system. That doesn't sound like how, understanding CalCare. Sounds to me like they're talking about developing recommendations for a bill that will please CMS and whoever shows up for these work group hearings. Again, if that strikes SB 770 proponents as unnecessarily cynical, please disabuse me of it. Why? Tell me why you picked that language. HCN is making the same argument that SB 770 authorizes CMS and stakeholders to write another bill. And again, I stress this is suggested. This is from an excerpt from Michael Leidy in a webinar produced by NUHW, I think back in April. And he says we have to, first of all, he justifies why we have to talk to CMS first before we pass a bill. And then he says, or does it make sense to have exploratory discussions with the federal government, figure out what the parameters are of support? Now, of support for what? A bill or a waiver? He leaves that a little open. Again, my mind wonders why he couldn't be more precise. And then use that information, gather other information on key issues from stakeholders, technical experts, and then present that to the legislature so what they pass will secure federal support. Does that not sound like it is the secretary's job, after talking to work group stakeholders, to propose a bill that will make CMS happy and the stakeholders happy? It's a reasonable inference. That's what I read into it. The next couple of slides just make the point that CMS's instructions to the states on how to apply for a Section 1332 waiver are voluminous. There's lots of it. And that's why I'd be surprised if someone would come back to me and say, Kip, here's a good example of a question that Gali could ask, even though he doesn't have a bill to show. It is not already answered by federal regs, commission report, or federal law. The website is loaded with advice. And you can see that the basic rules of Section 1332 are laid out here. State waiver application has to show that whatever it is they're asking for a waiver for is at least as comprehensive as the current Obamacare system. It'll provide coverage as at least as affordable. It'll cover at least a comparable number of residents, and it won't increase the federal deficit. There can't be any questions about that. It's already law. It's already in the regs. And I think everybody here knows this rule, that the application has to have a description and a copy of the enacted bill attached to it. Now, that does not say that CMS shall hang up the phone if Gali calls and says, I don't have a bill yet, but I want to talk to you. That's not what I'm saying. But it's crystal clear that not much is going to happen until the state can show a bill. I show you this. This is another web page on the CMS site on their Section 1332 checklist. It goes on for 15 pages, and it refers to even more information in the Code of Federal Regulations. This is an interesting little note that I think was added under the Trump administration. States are encouraged to engage with HHS early in the Section 1332 waiver application process to review draft legislation. Now I think they're loosening up a little bit, and they're saying, well, you don't have to pass a bill first before you talk to us, but please don't bug us if when we ask you for draft legislation, you can't give it, you can't show us. That makes sense to me. Will Gali have draft legislation? Not to my knowledge. Is he going to draft one? I sure hope not. The Section 1332 regulations go on, use up 5,200 words, and they go on for 14 pages. The Healthy California for All Commission makes the same argument that the state really doesn't have to pass a bill first. It actually makes more sense to think about passing a bill and getting a waiver as an iterative process, where you keep checking in with stakeholders and CMS, and then you go back to constituencies. And when you finally have had enough talking to CMS and constituencies, you then specify a preferred approach and then bring that to the federal authorities. Now, I don't know if a preferred approach even means a bill. It's another example of the really unnecessarily vague language. It was the California legislature, as far as I can tell, that concocted this fuzzy phrase, unified financing. I can't tell you why, if I were writing a bill and I wanted an estimate of the cost of universal coverage under a multiple payer bill, single payer bill, I would have said that. We're going to create a commission. Your job is to model one or more single payer bills and one or more multiple payer bills, and pick one or two or three and report to us on the costs and other features about them. Instead, what you get is this annoyingly flabby, ambiguous concept, unified financing system. It was first dreamed up by the people that wrote AB 1810 in 2018. And then SB, some photos are blanking the number for me, but a Senate bill was introduced that replaced AB 1810, changed the name of the commission, and but used the same unified financing system language. The Healthy California for All Commission clearly defines unified financing to include a multiple payer system. Now note how they describe it. Under unified financing, all health plans or systems would be required to offer the same set of benefits and co-payments. Each plan or system will have a single contract with healthcare providers. What that means is these are payers. They get the money first and then they pay out to the healthcare providers. That's a multiple payer system. Multiple payer systems have much higher administrative costs than single payer systems. Now, here are two examples where HCN proponents are making statements that I can't believe they think are true. Here's Ian Lewis, who wrote that study I called your attention to back in slide 3 in an interview with Code Whack. I don't know what that is, but I think it's a podcast. He says, let me start with the term unified financing. What the commission means by unified financing is a system where tax revenues are used to pay for all essential health services. That's not what a single payer means. That if you said, tell me what universal coverage means, yeah, that would make sense. But that's not what a single payer is. He says that is the definition of a single payer. Tax revenue covers all health services. How does he think that a system like that can cut administrative costs by the equivalent of 15% of $4.3 trillion at the national level, if all you can say about it is that it funnels all sources of taxes into one bank account? And here's Michael Lighty on a webinar sponsored by NUHW. He says, so what is the unified public financing system? Well, look at the characteristic of what they call unified financing. He had a slide up for this. I think it is single payer. A single source would pay for healthcare services for California residents. Now, if you would have said a single source would pay for healthcare services and the payment is directly to doctors and hospitals, not insurance companies, yes, this would be accurate. But to simply say that there's one trough at which all the health insurance companies can suck, that does not define a single payer. So this worries me. I don't know why it is difficult for Lewis or Lighty to explain clearly what a single payer system is. Clearly how a single payer system cuts administrative costs enough to save 15% of a state or national bill. Another issue to worry about is the commission and HCN are promoting the premise that you cannot do anything useful unless you get the feds to agree to roll Medicare and Medicaid monies into either your multiple payer system or your single payer system. I understand the argument. If you've got Medicaid as a separate payer and Medicare as a separate payer, and then one single payer for everybody who's not in Medicare and Medicaid, yes, there is a slight increase in Medicare costs, Medicaid costs, but there's a workaround for that. It doesn't take a genius to imagine what that workaround would be. But this just goes uncontested. One SB 770 proponent that I asked, why do you say this? He said, oh, we've always assumed that rolling Medicare and Medicaid into the same bank account is foundational. Okay. Commission argued that Medicare and Medicaid funds will require a change in federal law. So you can begin to see how, if you wanted to kill off single payer at the state level, here's one way to do it. First, you make it a part of your religion that if you cannot get Medicare and Medicaid waivers, boom, stop. Single payer is dead. And then you come in and say, well, and it's possible that we aren't going to get Medicaid and Medicare waivers because we may actually have to get a change in federal law. You see that statement made here by the commission. If this myth takes hold, I do think a lot of legislators, not just in California, but in Minnesota and elsewhere, are going to glom onto it as an excuse. Oh, no, don't bother us about single payer here at the state level. I'll skip over this commission again, saying that we have to get agreement with the federal government even before we write a bill on how much Medicare and Medicaid money we're going to get. I don't know why your common sense doesn't tell you that's not possible. Here is an example of what the old SB 562 said. They essentially gave the new single payer board the option to make all necessary arrangements to change the program if you can't get Medicaid, Medicare waivers. I won't stop here. This is a little hard to read, but this is an example from our single payer bill here in Minnesota, clearly laying out how we expect to get waivers. So once the bill is passed, now you've got these instructions. The single payer board shall do the following: contract for an actuarial analysis. Don't even haul off and write an application for approval. First, you've got to contract with people to analyze what's going to go into the waiver application, and so on and so on. We're not doing it the other way around. Let's have our Commissioner of Health phone up the Secretary CMS and say, if you got time to negotiate about waivers. Here is a suggested workaround for a state in the event it does not get Medicare and Medicaid waivers. As you know, states already administer Medicaid programs. State Medicaid agencies can submit bills to CMS for Medicaid eligible residents. Medicare beneficiaries carry their Medicare cards. State single payer program can wrap around Medicare, pay for the gaps or added benefits. Providers could just submit bills to the state plan as the gap insurance. Here is a quote from the report of the Assembly Committee on Appropriations for the hearing on July 12. It's already gone by. Cal HHS notes this bill would take effect January 2024, and even if work were to begin as soon as the bill is signed, it is not feasible to convene the work group, develop a recommendations report, and submit it to the legislature by June 2024. I don't know what you say about that. Anyway, I've used up my time that I said I'd use. If you want to go back and talk about the slides that I had developed for discussion about the pre-AB 1400 bills, we can do that. Once again, here are the questions I would love both wings of the California single payer movement to discuss and come to some agreement about, either after the bill passes or before, preferably before. But if it passes and there's some reason to think it succeeded, great, let's have this conversation. But if it fails or fizzles, let's have this conversation as well. I think if we can get agreement on what the bill's purpose was it to write a waiver or to write a bill? On why anyone thought you could get useful advice from CMS before you enacted the bill? Did HCM really think that CMS would say, oh yeah, here's how much Medicare and Medicaid money you're going to get? I'll tell you, I'll be the first to jump up and down and come back and say, boy, I blew it. If Galley calls up and he gets a solid estimate and it's good for 5 or 10 years. I hope we can abandon use of unified financing. I don't know why it needs to be used much beyond now. Can we get some agreement that Medicaid, Medicare waivers are not necessary? We'll find out soon whether this deadline was too short. And at some point, and I think this is a carryover from, where are we, 15 years of so-called single payer bills with the Kaiser HMO capitation loophole. I hope at some point, this division over whether a California universal coverage bill has to include Kaiser or does not have to include Kaiser. And it would really help if people who promote the Kaiser loophole would tell us, what is it you think bad would happen to Kaiser patients, Kaiser doctors, Kaiser hospitals if AB 1400 is passed? And I will stop there.
Thank you so much, Kip. Okay.
Kip, you still have a few minutes if you want. You still have until, you have another 5 minutes if you.
Oh, let me bring up,
continue.
yes, let me bring up these first slides. These again are the fundamental elements of a single payer. You have to have these four. Now, if you for some reason didn't do budgets for hospitals, you didn't give a hang about uniform fees for doctors, and you let the drug companies charge whatever they wanted, you'd still have a single payer system if you had one payer paying doctors and hospitals. It just wouldn't be an ideal single payer. You'd still be saving a lot of money on administrative costs, but you'd be driving up administrative costs slightly for hospitals and nursing homes if you didn't use budgets. So I want to make a distinction here. These four components make the ideal single payer, but if you at least have the one payer, you can still refer to it as a single payer. Traditional Medicare is an example. It's not the ideal single payer, but it is a single payer. It's a less than ideal single payer. Here's again the quote from Ian Lewis, recognizing that huge savings come from a true single payer system. I don't know why he would then tell Code WAC that it only means that all the money comes from the same account in the state treasury. Here is the HMO loophole that was written into all of Senator Kuehl's bills and then into the successor bills. And it didn't say HMOs are authorized. It said Californians may enroll in an integrated healthcare delivery system. And it means a provider organization. Now that's a little misleading because once you start bearing insurance risk, I don't care who you are, you have to act and function like an insurance company. It meets the following criteria: is fully integrated operationally and clinically. Now, it's not hard to interpret what operationally means, but no one knows what this means. And I'll give you some evidence to that in a minute. But note what the problem here is. If this was actually written just for Kaiser, or maybe for Kaiser and a few Kaiser wannabes, any insurance company that ever harassed a doctor is going to crawl through this loophole. So if we get back to a real debate about whether to insert an IDS loophole in CalCare, I hope we have a vigorous discussion about what clinically integrated means and whether this definition is so tight that it would keep out Humana and every other insurance company that does utilization review, has an EMR, et cetera, and is compensated using capitation or facility budgets. Nowhere do you find facility budget defined. Everybody knows what capitation means. And elsewhere in the bill, we find a statement that residents have to enroll in and withdraw from integrated delivery systems. All right, that tells you that capitation is how these IDSs, HMOs are going to be paid. Now, here's a humorous illustration of how incredibly difficult it is to define integrated care. You may recall that the Affordable Care Act authorized accountable care organizations to be inserted into the traditional Medicare program. And the concern was that if they didn't get the Justice Department and the Federal Trade Commission, the two federal antitrust authorities, if they didn't get them excited about ACOs, they might stop the consolidation that the ACO fad encouraged. And so Donald Berwick, who was at the time, I'm trying to think what his position was. Anybody remember his position within the Obama administration in 2011? Was he CMS administrator? I can't remember.
Yes.
He was? Yes, okay. And so he called a meeting of 5 experts on clinical integration and the heads of or higher ups, upper brass in DOJ and the FTC. They sat around for 2 hours trying to get a consensus to educate the antitrust people on what integration looks like. And Berwick spoke as if he were a 15-year-old boy falling in love with his girlfriend for the first time about ACOs. Couldn't describe what they do, he just waxed incredibly poetic about what they do. The ACOs start a journey. In any event, when they've turned to the experts to say, tell us what integrated care means, here's what one Dr. Lee Sachs says. Okay, I guess I get the first 2 minutes. You know, Don Berwick said minutes ago that when you experience clinical integration, you know it. I've always been struck by something I read from Steve Shortell, another prominent ACO HMO advocate. His analogy to the Supreme Court ruling on pornography. When you see clinical integration, you know it, but you cannot define it specifically. Now imagine you're a judge and you're in California and you've got a case in front of you. Humana is saying, we are clinically integrated. Prove we aren't. And nobody can. So this definition that has been in so-called single payer bills in California between 2003 and 2017 is just a huge open door to the rest of the insurance industry because it's so flabby. AB 1400, on the other hand, did not authorize HMOs, ACOs, IDSs, and it did authorize hospital budgets. And here's an excerpt to that effect. Not later than beginning of any fiscal quarter during which an institutional provider of care, including a hospital or a skilled nursing facility and a dialysis clinic, is to furnish healthcare items, board shall pay to each institutional provider a lump sum under a global budget. Very simple to propose. I don't think I have time to, Maureen, tell me, should I stop
yeah,
here?
you have actually 3 more minutes at 6 o'clock.
Okay.
Those that want to, those of you that would like to ask a question, please put yourself on stack. We have Betty Dumas Toto is already on stack. So
All right.
you have until 6 o'clock.
This is the last slide in the section on pre-AB 1400 bills. PNHP, the National PNHP office arranged for me to debate a Kaiser doctor at the 2013 National PNHP meeting in Boston. And on the day that we were supposed to debate, it was an outgrowth of these phone conference calls I told you about. I think people thought they were interesting. On the day that we were supposed to debate, some insane gunman shot up the LA airport and he never made it to Boston. So we continued to talk occasionally by email. And Don, I think you may have been in some of these. I'm not going to mention his name because I'm going to criticize him. Don knows who I'm talking about. And at one point I just said, could you, I accept that you as a Kaiser doctor are providing superior care. I believe you. But could you tell me why, if a bill like AB 1400 is passed, you will no longer be able to do that? And I sent him these questions, and I'll just read you the first one. What is the evidence for the claim that high quality care offered by Kaiser, the high quality care you offer to Kaiser enrollees is dependent upon Kaiser's current form? Would you just become another run-of-the-mill doctor if Kaiser lost its enormous market power to extract lower prices from its suppliers of goods and services. Kaiser patients were free to see other doctors, use other hospitals, and know they wouldn't get stuck with a bill that Kaiser wouldn't pay. Society would determine Kaiser's hospital budgets rather than Kaiser execs, and Kaiser could no longer use financial incentives and utilization review to reduce utilization of medical services. Now, I don't know if that sounds divisive to you. To me, that sounds like an eminently sensible question to ask. And his answer was, I appreciate your question. I need to think about it. And that was in 2019, and he hasn't gotten back to me. I would think that if you were advocating against or for the Kaiser loophole, and you'd been advocating for 15 years, you could answer this question right off the top of your head. This is a question, I would love it. If anybody on this webinar tonight can help me, can you get anyone who defends Kaiser, who expresses worries about AB 1400 on the ground that it will do something negative to Kaiser? Could you get them to tell you what the negative, what negative outcome they fear? Or better yet, could you get them to write an amendment to CalCare in their mind that satisfy this nagging, never describable feeling that something bad will happen to Kaiser if we don't restore the Kaiser loophole to a bill like CalCare?
Thank you
No, I
so much. Oh, sorry, Kip. It's
think
time
I'm
for
done now.
questions. I'm sure that you'll be sharing a lot more. So if you'd like to get on Stack, please write Stack. So far, we have, and I'm going to ask you to unmute yourselves. Betty, Bella, Taiji, Cheng Sim are the first four. Betty, can you unmute yourself?
I thought I did. Okay, here I
There
am.
you
Hi,
go.
Kip. Hi, Kip. Hi, everybody. Thank you for that. I do have a question about the term, I guess, unified healthcare system and its, its meaning. And my question was, I don't know if this is well put, but can a unified healthcare system for California include the state paying for healthcare and Medicare paying state healthcare for seniors, therefore unifying these two sources of funding? Would that, I guess, in fact, be considered unified healthcare?
That's the commission's definition of it. And that's the only definition, as you saw Michael Leidy and Ian Lewis say. The only definition of unified financing is all the taxes, Medicare, all the revenues, all the taxes raised by the Medicaid program, the Medicare program, and ideally the VA, et cetera, all go to the same state account.
That's
bank
not what
account.
I'm asking. I'm sorry. Let me be clear. I'm sorry. That's not what I'm asking. Under the term unified health, I'm trying to rephrase this so that it's, I'm sorry, it's wordly. I've worded this, it's a difficult thing. If you have a single payer system in California, and underneath that single payer system, you're able to get authorization through 1332 if there has to be taxation, and then the system, okay, that is in California that is put in place pays bill. But Medicare, I guess you consider it underneath the wraparound. Medicare, they don't pay Medicare bills. The Medicare system pays the bills.
That's correct. And if you don't get a Medicare waiver, that will continue to be the case. The question we have to ask is how you get the bills to Medicare. And the simple answer is doctors who treat Medicare patients send the bill to the state single payer. Now that means you're incurring a few more administrative costs than you would if the state single payer already had Medicare money. So you're spending a little more money on billing. Doctors shipping the bill, state single payer billing Medicare.
Thank you, Kip. Next, Bella, unmute yourself.
Thank you. Can you hear me?
Yes, I can.
Great. Thank you, Skip. It's been great. Great presentation. I'm new at this. A few questions. First of all, what is this is stupid, obviously, but most of you know this. CMS, what is CMS? I have my questions, but I need to be clear on that.
I'm sorry. Yeah, I wish you to stop me right then. Anytime I use jargon, you
I
haven't heard.
couldn't, I was muted.
Okay, well, it stands for Centers for Medicare and Medicaid Services. The
Oh,
old name,
okay,
and
so
it
this is
runs
the
Medicare. and it-
Center for Medicare and Medicaid, Medicaid,
Medicaid Services.
Medicaid.
And the Bush
Services,
administration
got it.
dreamed up that
Okay,
title in
then-
2001.
Okay, then, okay, something about AB 1810, did I get the wrong number?
That, I mentioned that bill, yes.
Then I did get the right number, okay. What I got confused with was the waivers. Because it seems to me that the waivers in the present system, well, they are working, but again, there's a lot of admin expenditure that could be cut, right? And this is what single payer is aiming for, to cut off all the fat. So I'm now confused because I thought the waivers have already been embedded in the present system. I wrote down the 4 elements of the single payer system. But does that mean that in order, let's assume that we can pass this, it gets done. That means that it would require waivers, new types of waivers, or am I confused?
It would help if SB 770 would be precise about this. They're not. They just use the generic term waiver. Here's a 1-minute tutorial. When the Affordable Care Act was passed in 2010, Senator Ron Wyden said, we don't want to foreclose experimentation at the state level. So he saw to it that the Affordable Care Act had a section 1332 in it that said, look, states, if you want to do something different from Obamacare exchanges, here's the process. You have to come in with an application that meets these criteria. That's the section 1332 waiver, and you have to have one if you want to do a single payer. The other waivers that are part of the
Can I stop
conversation.
you? I'm sorry, Kip. Let me stop you there. So you're saying that waivers are indispensable, they are necessary, because that was one of the questions that kept coming up in your presentation. So even with single payer proposal, the waivers are necessary. That's what I'm trying to get clear at. Is that correct, or is that?
You beat me to the punch. Let me finish my statement.
Okay,
You have to apply for a section 1332 waiver to undo the requirements of the Affordable Care Act on your state. You may want to apply for a waiver from a Medicare law and Medicaid law to also add Medicare and Medicaid funds to the state treasury from which you will pay, that will run the single payer program. So the section 1332 waiver is essential. The Medicare and Medicaid waivers, most people think are desirable. If you get me going on them, I'll give you some reasons why I don't particularly like the idea of Minnesota being hooked up to a Republican Congress that might screw around with Medicare and Medicaid. But most people who promote single payer at the state level think that that Medicare and Medicaid waivers are very desirable. And as I said, HCN and the commission are promoting the notion they are absolutely essential. That is not true in my book. Section 1332 waiver is essential.
Thank you, Kip. And Bella, if you have more questions, you can always contact me.
Yes, thank you very
Contact
much.
me. We have
I'm
several
clear.
other people that have questions, so I'm happy to talk with you anytime. So you can contact me.
And Bella, last comment. Waivers have nothing to do with single payer at the federal level. Nothing.
Okay, our next person on stack is Taiji. Taiji, can you unmute yourself?
Kip, thank you for joining us today, and thank you to Healthcare for Us for hosting this very important event. Kind of related question, more of a macro, big picture question. We have some friends among us that have concerns that whether or not it's even possible to execute a single payer program at the statewide level due to the complications and possible limitations of financing, such as some people saying we can only go for the federal level because of MMT, right? And so there's also a concern possibly related to this and possibly not, depending on where people are coming from, where some people counterpose the efforts to implement single payer at the state level to efforts to try to win it at a national level. And, you know, of course, you probably are aware of the gradations of these positions, such as some people advocating the push at the statewide level to make it similar to the effort that happened in individual provinces in Canada prior to the adoption of a single payer system nationally there. Can you perhaps shed some light on there, maybe perhaps from your experiences in these efforts in Minnesota?
Yeah, I see no reason to be dogmatic about one or the other. I don't know if National PNHP still has that, I think, sectarian attitude, which is no point doing single payer at the state level. We just got to focus on the federal level. I don't hear it that much anymore. But I know there's some people out there that say that. I fell in love with community organizing. I have a law degree, but when I got out to the Bay Area and started working with a group called Citizens Action League, started by two Saul Alinsky organizers, Tim Sampson and Mike Miller, man, I fell in love with community organizing. And one of the rules of community organizing is you got to give people something to do around them. You can't be trucking off to Washington, D.C. for a hearing every 5 or 6 years and hope you're going to build an army. So the advantage of having a campaign at the state level to promote a single payer is you've got lots of targets. In fact, you can keep people like Maureen so busy, she takes her a couple of days to respond to my emails. And that's a wonderful problem to have. And so I would say to the people that push for national only, I bet you've never organized. I bet your heart is in the right place. I bet you've never tried to get people to come out from behind their TV and come to a meeting at 7 o'clock at night. I could say more about it, but I think that summarizes the issue. We should, I think you're right. I mean, Saskatchewan began the process in Canada. I'd love it if California were the first to begin the process. You guys have gotten fairly far along with bills that I wouldn't call single payer, but boy, even that I think showed strength of the movement.
Thank you, Kip, and thank you, Taishi, for your question. Chang Sim Lim, you are next on stack. Please unmute.
Hi, Kip. Thanks so much for the informative session. I have a comment and then a question. My comment is, I actually think you're too kind to the proponents of SB 770 because you give them a lot of credence for not answering, you point out the vagueness of the language, you're not getting answers or precision, it could be interpreted so many different ways. But the bill itself actually, does specify the kinds of features, because you had mentioned like that, the kind of bill that Gali would work on would have certain features. That's the language in SB 770. And those features, have language that are very clearly, to my reading, not single payer, very clearly multi-payer. So, and I just want to mention a couple of examples of that. It's a lot of this language is caveats and modifying clauses that
I'm aware of them.
Yeah. So, like the elimination of the distinctions that currently exist among the disparate systems of Medicare, Medicaid, employer-sponsored insurance, and individual market coverage to the greatest extent possible. Not just elimination of those distinctions, but it's to the greatest extent possible. So then the other part is a clause in the bill that you actually did show in your slides, is the elimination of the adverse impacts of insurers rather than just the elimination of insurers. So, those are just two examples. I don't want to belabor it. Just pointing out that this bill actually is more than just vague. Like when it's specific towards multi-payer, not single payer. That's my comment. And then my question to you is regarding AB 1400. So it was, apart from being the first true single payer bill in California history, to my knowledge, it's also the first single payer bill that had a provision putting a special fund to pay for, to resource underserved areas in California, rural areas, urban areas that are underserved in terms of their healthcare delivery, and also to put resources towards prioritizing multicultural and multilingual competencies in healthcare in California. So that is a really incredible provision in the bill, because it makes single payer not just single payer in terms of saving money, but it really prioritizes healthcare as a justice and equity bill. So I'm wondering, since you know so much about single payer, state single payer, and national single payer, whether there are other single payer bills before and current that have that provision, or was AB 1400 the first to have that?
But I try to keep track of so many bills that when you get to this level of detail, I'm not absolutely sure. I will just tell you, I know for a fact that the Minnesota single payer bill authorizes the single payer board to move money around to make absolutely sure that everybody has equal access to hospitals and physicians. That I can't imagine a more important provision in any bill, even if it wasn't a single payer bill, in order to end the serious inequities we have in access to hospitals and physicians and nurses and nursing homes, and even MRIs. There are 4 MRIs in one of the wealthy counties in the East Metro here in the Twin Cities, and you can go for miles throughout rural Minnesota and not find. So I think the short answer to your question, without giving much detail, is my impression is that most single payer bills do make a point of saying the board is authorized to do whatever necessary to guarantee equal access. And a quick comment on your testimony. It's a pleasure watching your testimony before the which committee was it? Senate Health Committee. You think fast on your feet.
Thank you, Kip, and thank you, Cheng Sim, for your questions. Leland Young, you are next. Would you please unmute yourself? Hi, Leland.
Hi, I had a question about waivers. Maybe I don't fully understand it, but my understanding is it's used for Medicare, Medicaid, and ACA. And the profit generating people are the working population. So what would happen if we didn't, if we couldn't do waivers and you just have the working population, all the insurance companies are gone from them, and we just get, my understanding of the working population, they're the profit generating population. So if we just have them, with the profit we get from them, would that be enough to pay for long-term care and for the people that are uninsured? And then you have the insurance companies cover the people that are more expensive, the Medicaid, Medicare people, and then maybe they would want to quit and just give up. I'm wondering, why is it necessary to have waivers? Or why is it's good to have, but what would happen if we don't get those waivers?
If we don't, I didn't quite follow the first part of your question. Let me answer the last one. If we don't get the Section 1332 waivers, we can't get rid of insurance companies, because otherwise the Affordable Care Act says all states have to run these exchanges.
But the exchanges, aren't they a very small population? So the working population is a huge population, maybe over two thirds of the population is covered by the working population. So
I see what you're saying.
exchange, I thought, it's a very small population. So if we only got rid of the insurance companies with the working population, that's where the insurance companies make the most money. So then they would be covering the population that are the most expensive. And then we would get this profit generating population. And then we could use that in profit to pay for the long-term care and the people that have no health care. And then what they want to quit, they said, we can't cover this, then what they quit and just to make everything a single payer.
Well, that's a fascinating idea. Essentially, you're extending my idea of a single payer for the non-Medicare Medicaid population. How about a single payer for the non-Medicare Medicaid Obama exchange population? I don't know why it couldn't be tried. Yeah, no one's ever proposed that before.
Because right now the government is paying for the biggest for the people with the highest medical expenses. So why don't you just have them do that, and we get the people that that generates actual profits?
Yeah, it's a wonderful idea. We should begin thinking about that, because you can imagine that an antagonistic administration, or even a Biden administration with an antagonistic HHS secretary. By the way, the Section 1332 waivers have to be signed off by two secretaries, Secretary of HHS and Secretary of Treasury. Beats me why Treasury has to get its nose into this issue. But in any event, the odds of being turned down, especially by a hostile president, are pretty high. So we may need to think seriously about your proposal.
Thank you very much, Leland, and thank you, Kip. We have time for one last question. I see Shirley. Shirley, did you want to ask your question? Shirley Toy? You can unmute if you'd like to ask your question.
Well, I guess my question I have too is, what is your advice on how maybe we could be united more in California? I don't know. It just seems so sad. And then what Leland was offering, though, wouldn't that be a public option? And don't we not want that public option? I don't know.
He wasn't promoting. Just again, for those of you who don't know what a public option is, what it basically means is that the state sets up a program into which anybody or people below a certain income level can buy. They can, if you're willing to pay premium of whatever the state program is charging, the state will let you in and they will insure you. I didn't hear Leland suggesting that. I heard him saying one payer for the entire non-Medicare, Medicaid, ACA population. Now I've already forgotten your other question.
I think it was how we can solve this rift.
Oh, yes.
I think we have some answers in the chat as well, but
my solution is to get people together and have discussions on these questions. There may be other good questions to ask, but you can't force people to come in and have a discussion on these questions. But I do think if everybody, and by the way, my sense is that reality is going to kick in real soon. And if you think the Chicago Cubs are about to win the World Series, okay, go ahead and predict it, but we're going to know by October whether you know what you're talking about. And we're going to know by June 1 whether the people who wrote SB 770 were proposing anything that can produce workable solutions. So I would hope that we could have these debates before 770 passes. And then at minimum, after June 1, when we can look back and say, all right, what did we accomplish? What did we lose? What did we gain?
Thank you, Kip, so much.
And done with sincerity.
Yeah.
And I'll put it as somebody from another state. If something good comes out of this, by God, I'll be the first to go run around and say, hey, look what HCN proposed. I can hear Chung Sim saying, Chip, what are you talking about? But I mean, I just want to reveal my sincerity. I'd love to have a debate where you get to convince me. You should do this in Minnesota.
Yes. This ends our wonderful session with you, Kip. We have a little bit more to say, and I'd like to call on, thank you so much, but we have some information about healthcare for us and also about CalCare we'd like to share with you. And Carol Fodera, would you please unmute yourself and tell us who you are? Carol is on our board, and she's our corresponding secretary and our outreach team member. Carol, you
So-
want to unmute yourself?
I should be unmute. Can you hear me?
Yes, we can.
Okay, great. So we're always trying to get more volunteers. And I put the link for volunteering in the chat. So that our process starts with filling out that volunteer link. And then you and I will talk on the phone, which gives me a chance to find out about you. And then you can ask questions about our organization, Healthcare for Us. We also have a Signal. We use Signal, which is an encrypted messaging service, and that allows us to communicate one-on-one and group texting. So that's part of our volunteer process. And then for our teams, I thought what I would do is tell you some of the activities that we've done and what we need volunteers to do. Our political team is led by Gina Viola, and they have coordinated actions with the Progressive Caucus of the California Democratic Party at the convention in LA this year. 30 of us went up to Sacramento and spoke against SB 770 at the Assembly Health Committee hearing. And Kip was referring to Chang Sim giving extended testimony. And yes, I agree, she did a great job. We've also had Zoom meetings with several elected officials regarding SB 770 to advocate that, of course, that they don't vote yes for it. Our outreach team is led by Chang Sim, and there's a lot of overlap, of course, between these teams. But, you know, we're working on creating partnerships with other organizations. We have a presentation speaker training team. And our big goal right now is to educate groups about CalCare with speakers and slideshows. Website tech. We need people to help with graphics and web design using WordPress Elementor. We need volunteers to take photographs and produce videos. Our social media communications, we're on Facebook, Instagram, Twitter, and TikTok. And so volunteering ranges from sharing those posts to creating posts and using analytics. We have emails using Action Network and help with analytics so that we get our message out to as many people as possible and keep them with us. That we need help with that. There's always phone calls and texting to increase attendance at events. Events and actions team. We had a table at the Black Lives Matter 10-year anniversary celebration in Los Angeles. We collected CalCare signature petitions. And we handed out popsicles too. It was a warm day, so we lured people in and they were really receptive and signed the CalCare petition. And then when CNA had the CalCare town hall with Ash Kalra, we were a co-host at that town hall. We had our table with handouts. We held up no on SB 770 signs. And I have to mention our CalCare bear. We have a wonderful CalCare bear, which is like a blow up bear. And whoever is inside that bear, and Erica was our last bear. It's a great icebreaker, and it just really helps add some levity to these events. So, and then last but not least, we have our membership fundraising team. And I think Erica will talk about that, our event that we have for fundraising.
Thank you so much, Carol, and thank you for all the work you do. Carol does so much behind the scenes work, as does everybody on our board, but she's doing a lot of work. So Cheng Sim, you want to talk to us about CalCare canvases, assembly phone calls, and the day of action, yes? So please unmute.
Yes, I just wanted to amplify what Carol said, is that, you know, we need everybody to be involved and active, because we can't win CalCare if you know, just a few people are, you know, doing all the work. So I really want to encourage everybody to sign up and join us in HC for us, as Carol was saying, all these different committees you can get involved. And there are specific actions coming up I'll draw attention to, but for now, just wanted to say that you know, we have to stop SB 770. We have a good chance. We have the best chance we have right now, while the bill is in the Assembly Appropriations Committee, because the Appropriations Committee has actually issued their own report saying, as Kip said, that the timetable of SB 770 is not feasible. So you have a bill that it has a not feasible timetable. So, and we need everybody to call every week through August the 31st, because they'll probably, you know, make their decision, or, you know, announce their decision on September 1st. So every week, please call the Assembly Appropriations Chair, Chris Holden, and if you represent an organization, it's really, really important. It's very impactful. Get your organization to send an email to the Appropriations Committee. We have already posted in the chat the bit.ly. It's bit.ly/stop SB 770. If you go there, there are all the details of the phone numbers, the sample email, and phone script that you can use to call and email. So please do that. Tell everybody you know to do that in California. Stop SB 770. But stopping SB 770 alone is not the only thing, right? We have to win CalCare. And to win CalCare, we need all of you to get involved. I believe the volunteer link is in there. And you know, we work with many partners, including API for CalCare, CNA, Hollywood for CalCare, the Healthcare Justice Committee of DSALA, like Carol said, Black Lives Matter as well. So we work with a lot of different partners. So if you know, so we encourage everyone, find the partner, you know, that you want to work with, you know, or come work with us, and then, you know, work with those partners through HC for us. And we do a lot of work in when you sign up, and the volunteer link in the chat, you'll see, you can choose what, you know, parts, you know, what interests you, you know, whether it's outreach, political, you know, social media, etc. But there's also a checkoff for whether you want to join us in the Signal chat. And most people think that that's nothing. We get a lot of work done in the Signal chat. So if you join us, please check yes to be in the Signal chat. Okay, thank you.
Thank you so much, Cheng Sim, and for all that you do, because everyone on our board does tremendous amounts of work. Our partners as well, and the organizations mentioned, are all working with us, and we are all volunteers. We don't have any paid staff. So to wrap things up and give you some fun information too, Erica.
Hello, everybody. Thank you all for coming. Thank you again, Kip, for putting together this presentation. I do want to take this time to really emphasize, I know that I've seen some genuine single payer supporters make comments like, first let's pass 770 and then we'll pass CalCare. And I want to make it clear that 770 is designed to stop CalCare. It is designed to give legislators an out to withhold their support from CalCare by saying, oh, I need to wait until these 770 reports come in before I can decide whether to support CalCare or not. And as the Appropriations Committee has shown, as Kip Sullivan has shown, these reports from 770 can go on in perpetuity. So that's why it is imperative that you take action to stop 770. And then, of course, continue to take action to pass CalCare. And then Gina, Viola, and we are going to be at Elysian Park tomorrow at the Los Angeles for All event, tabling for CalCare. So if you're in the Los Angeles area, come by, say hi. And the fun thing that we're doing is it's fundraiser. I know that part doesn't sound fun for our organization, but it is stand-up comedy. And if any of you are fans of the television show Hacks, it's an Emmy Award comedy series. The star of the show, Hannah Einbinder, is our headliner stand-up comedian. And this event is going to be on August 22nd. I think somebody can drop the link in there for me. But you know what? You can just go to our website, hc4us.org, and tickets, you'll see the link for the fundraiser. So if you like stand-up comedy, you're in the Los Angeles area, get your tickets. And I believe we have 4 tickets left. So we're almost out.
Yay. Erica, we have one more comment from Cheng Sim. She forgot to mention something.
Yes, come on in, Cheng Sim. Unmute yourself.
Muted.
You're still muted.
Unmute yourself.
There you go.
Okay, there. Yes, and after the fundraiser, CNA has a day of action or set for September 23rd, when we're going to be pivoting to more looking at district by district, how we're going to win CalCare, organizing district by district to win CalCare. So put it on your calendar. We need all of you to show up for that event, because that will be the time when we're going to get everybody together and start the as Ryan here would say from the CNA, the on-ramp to organizing, so that when the new CalCare bill is introduced in January of 2024, we will be, ready and, district by district, we know, who needs pressure and who doesn't need pressure. So all that work is going to be starting in the fall. So join us on September 23rd for the CNA Day of Action.
Hey, Erica, you want to close us out here? Thank
Yeah.
our
And
yes.
so last thing, I was just typing it in chat. You can listen to the Healthcare for Us show on KPFK 90.7 FM every second and fourth Thursday at 5 p.m. I see Bella's representing KPFK in the background. So tune into KPFK. It is the People Power Radio. With that, again, the radio information, the comedy fundraiser, everything that CNA is doing, our canvassing, it's all at our website, hc4us.org. Thank you all again. Thank you, Healthcare for Us team. Thank you, Maureen. Thank you, Kip. And good night.
You guys are awesome.
Good night, everybody. Take care.